session, it gives me an immense pleasure to invite our speaker, Dr. Rahul Bade, and the topic is Advancement in Knee Surgery, Enhancing Patient Outcomes Through Innovation. And to conduct the session, we have Dr. Vinayak Ghanate, sir, currently working as Senior Consultant and Joint Replacement Surgeon in Manipal Hospital, Baner, specializes in complex limb reconstruction and revision joint replacement surgery. Can we have you on the dais, sir? And Dr. Srikant Madikattu, practicing as consultant orthopedic surgeon in Manipal Hospital, Baner, with keen interest in joint replacement and arthroscopic surgeries. We welcome you, sir. Can we have the speaker on the dais, please? Dr. Rahul Bade, sir.
A fellowship in joint replacement surgery, fellowship in arthroscopy and sports injury in Barcelona, Spain. He is the founder and director of Bade Hospital in Somatne, Sparsh Hospital in Somatne, and Medistar Hospital in Balewadi. He is a panel consultant in Jupiter Hospital, Balewadi, and Manipal Hospital, Baner. Welcome, Dr. Bade.
Thank you for the introduction. It's a privilege to be here, and I thank you all for providing me this opportunity. सकाळी येताना असं वाटलं होतं की आपल्याला लेक्चर घ्यायचं आहे, पण इथं आल्यानंतर बरंच काही शिकायला भेटलं. राईट फ्रॉम द बिगिनिंग द introduction and the information provided by our chief guest, it was quite inspirational and motivational. आणि त्याच्यानंतर जे काही बाकीच्या स्पीकर्सनी बोललेत, so we have learned a lot from it. Being orthopedic surgeon, we are not used to use stethoscope, but after Prasad Bure sir's lecture, I think definitely we'll dare to touch the stethoscope. So coming to my topic, I am Dr. Rahul Bade, orthopedic surgeon who has specialized in knee surgeries. I am working at Medistar Hospital and Bade Hospital at Somatne. I am also at panel consultant at Manipal and Jupiter Hospital. I've been practicing, my work is mainly related to trauma, and currently my focus is on knee surgeries, which has like holistic knee care. So we cover everything in knee, right from sports injuries to joint replacement surgeries. So why this topic? The patients which I used to see 15 years back are completely different from the patients which we see today. The current patient, like today's patient which we see, is very highly demanding. They are well researched, they go to Google, they take the information, they take multiple consultations, and they are very demanding. They want minimal access, less pain, faster recovery, shorter hospital stay, and return to pre-injury levels. The aspirations are very high. So they want to do whatever they used to do before the surgery or before performing the procedure. Similar is the case with senior citizens. They want a pain-free mobility and want to travel around the world. So it's a need of an hour to keep updated, like update ourselves with the current knowledge. So the evolution of knee surgery, if you can see here, previously whenever we want to operate on a knee, especially the posterior compartment or posterior side of the knee, we have to take such long incisions, dissect through the popliteal fossa, and approach our lesion that may be a posterior cruciate ligament or a Baker's cyst. But with the advances in technology, both same surgeries can be performed with the help of simple stab incisions and arthroscope. As you can see in this image, the PCL avulsions can now be tackled with the help of arthroscopy, which is very minimally invasive, and patient recovers very fast with this kind of surgeries. The first part of my talk is advancements in arthroscopy and sports medicine. So this wouldn't have been possible without the use of equipments which we are using today. They are very high definition and 4K. We have got very good monitors, camera, arthroscopes, the LED light source, the highly calibrated instruments. These have definitely helped in improving the patient outcomes. Coming to advances in ligament reconstruction techniques. So when we look at sports injuries, the sprain is the most common form of sports injury which we see. It can be from grade 1, 2 to 3. So grade 1 and 2 can be managed with RICE, that is rest, ice, compression and elevation. And grade 3, in which there is an instability, the patient might need a surgical intervention. So previously, and most of us know that the most important ligaments which may be injured are ACL, PCL, MCL and LCL. But currently the trend has increased, and now we have to look at the other corners of the knee, mainly the posterior medial corner, in which we also repair posterior oblique ligament and the medial patellofemoral ligaments along with MCL, and the posterolateral corner, in which we reconstruct the popliteofibular ligament and reinforcement of ACL with anterolateral ligaments. So ACL surgery is the most common arthroscopic surgery which is being done today. So what is new in ACL reconstruction? So currently we do anatomic reconstruction. Previously they used to do a transtibial reconstruction, but nowadays anatomic reconstruction is possible where we match both the footprints, the tibial attachment and the femoral attachment. The next advancement is all inside ACL reconstruction, which is possible because of retrograde drilling, in which there is a less bone loss and a better fixation available with this all inside ACL reconstruction technique. Use of innovative grafts. There is a wide research on the choice of graft in ACL surgery. Nowadays, quadriceps tendon graft is quite appreciated and the use is increasing day by day. The graft reinforcement with lateral extraarticular tenodesis. So if a person is very high demand athlete and there's a chance of re-injury, now only ACL is not done, but it is reinforced with lateral extraarticular tenodesis. We have got biodegradable implants which integrate with body over time, and there is no trace of metal left inside the knee. The multi-ligament injuries can be treated with augmentation with fiber tape. So this is my one of my case study. He's a professional wrestler. His aspiration was to develop a career in wrestling. The problem which happened during his training was ACL and MCL tear. So the procedures performed was ACL reconstruction, MCL repair, and we augmented it with the help of like platelet-rich plasma to give it like a best chance to heal. So this was the video which he shared me after 1 year of intensive physiotherapy. So this is post reconstruction, and he just wanted to know whether he can go in for a competitive wrestling. So finally there's no question after seeing the video, and I permitted him, and after that he went on to win the most prestigious competition in Maharashtra, that is Maharashtra Kesari Award. So next comes the cartilage restoration. So cartilage previously used to be the neglected part, and we used to think that we can't regrow cartilage, but nowadays with different techniques it's possible to treat cartilage. So there are basically two possibilities in this. The first one is regenerative medicine, in which we use body's own healing mechanism for cartilage regeneration, and the second one is osteochondral allograft transplantation, in which we take a donor or a cadaveric from bone bank, the osteochondral graft, and it is transplanted. So this is a microfracture technique in which we drill small holes, cross the tine mark, and get the blood flow. The cartilage which we get through this technique is a fibrocartilage. The next technique is autologous chondrocyte implantation, which is a two-stage procedure. It's for a relatively large defect in which the chondrocytes are sourced with the help of biopsy. They are sent to lab, cultured over there, and after a month or 6 weeks' time, it is reimplanted with the help of a periosteal graft. Our preferred technique is osteochondral autograft transfer. So in this case, we use or harvest a graft from non-articulating part of the same side, and it is implanted at the defect site. So this is one of the case study. So this patient, he came to me 7 years back. He was in his 30s with a huge cartilage defect in his trochlear groove and medial femoral condyle. So I was really wondering what can be done for him, and then we thought of using this technique. So after using Oates procedure, that is osteochondral autograft transfer, he is asymptomatic at 7 years of follow-up. Advances in meniscal surgery. So again, the meniscus surgery has changed over the time. Previously, meniscus was trimmed or it was removed and the torn fragment used to be removed. But nowadays, meniscal preservation is very important and meniscal repair is done routinely. This is all possible because of all inside repair devices. We usually augment the repair site with the help of PRP. The next thing which is upcoming is meniscal transplantation, and which can now, within coming few years, it is going to be very much possible with the availability of donor meniscal tissue. So this is again a case study. A 12-year-old male child with history of neglected bucket handle tear on left side was roaming around for 2 years undiagnosed, which healed in a very deformed manner. It was treated and reshaped with the help of arthroscopy. Then he again refalls and develops a bucket handle tear on the right side. So it's not a good idea to just trim the meniscus in such a small age. So he came to us in time, and we had an opportunity to stitch it with the help of arthroscope. As you can see here, there is a small fragment of meniscus which is trapped between the femoral and the tibial condyle. It was repaired with the help of a meniscal suture using different techniques, that is all inside out, and outside in. The advances and use of osteotomy around the knee. So the osteotomy nowadays is again come into picture. Its role is not only limited to deformity correction, but nowadays osteotomy is also performed for multi-ligament injuries. Coming to the second part of my topic, that is advances in knee replacement surgery. So you all are aware, like, it is one of the best innovations of modern orthopedics. Millions of people are having a pain-free life with this surgery. So robotic assisted knee replacement surgery, the precision at its best. It's definitely the thing in the coming future. The limitations are it's only manufacturing company driven. It adds cost. Most insurance companies do not cover the expenses. But over the time, robotic assisted will be the most preferred treatment. The other important thing in joint replacement surgery is the advances in prosthetic materials and designs. The material innovations in polyethylene. So the spacer or the polyethylene which we use currently is highly cross-linked polyethylene, and it is reinforced with the help of vitamin E. So the life in this polyethylene is about 25 years. There are advanced alloys which we use, the titanium and cobalt chromium. The gold knee, which we have all heard of, is made of titanium nitride. It is preferred in patients who are allergic. It has got the least allergen or the allergic tendency. So whenever a patient is having an allergic tendency, it is recommended that they go for a gold knee. The design enhancements are helping patients with the gender-specific implants and high flexion implants. Pain management innovations, again, they are making this surgery as pain-free as possible. The post-op rehabilitation protocols are in place, so the patient is mobilized and rehabilitated very fast. Breaking the myth, so it's commonly said that sitting cross-legged is not possible after knee replacement. Like whenever you tell a patient you need a knee replacement, he says that I will not be able to sit again. It's not so. Because of new prosthetic designs, patients can now very well sit cross-legged. It's not successful in severe obesity. Definitely it's a challenging, but it's successful. The difference here is, what we need here is like motivation, lot of education, physio, and it's a teamwork. So summing up, advancements in knee surgeries are not just technological feats, but gateways to improve patient lives. By embracing these innovations, we can offer hope and enhance quality of life to those suffering from knee ailments. Thank you for your dedication to the patient wellness and for your time today. Thank you.
Thank you, Dr. Bade. Thank you for touching all the points and covering all the topics in the knee. And it was excellent, and it did mention about robotic. Would you recommend a robotic knee straight away over a conventional?
I usually prefer conventional, but robotic in some sittings.
Okay.
Yeah.
Right.
Because it's still, I think it needs a lot of research, and it's again company driven. So
Yes.
we can't use all the implants for the robot.
Absolutely,
Right.
I agree with you. It is company driven. Right now, we do not have sufficient data on robotic that the robotics knees last more than 25 years, because conventional do last for 25 years. We know that. So until we have the data, we can't
Yeah.
say it for sure.
Right.
Yes. Right. Anybody has any questions? We have a couple of minutes here. Now, you want to move on? Thank you. Thank you,
you.
Dr. Bade.
Yeah.
Thank you, sir, for a wonderful session. I would like the chairperson to please felicitate our speaker, Dr. Rahul Bade, sir. A big round of applause. Joint replacement surgery is actually the need of the hour. It has really helped a lot of patients to live a good quality of life. I would request Dr. Archana Dangre, medical officer in PMC since 5 years and emergency medical officer in 108 since 10 years, to please come on the dais and felicitate our chairpersons. Dr. Srikant Madikattu. I would request you all, there will be a Google form shared on the delegate groups, on a WhatsApp group, to please fill that form. It is mandatory for your MMC points also. So please fill the form, give the feedback so that we can have a better BMACon next time. And for the next session, we have Dr. Uday Chandkhede, and the topic is Uro-Oncology and Robotic Surgery.